Advance warm New Year greetings to the delegates of NATCON, National Indian Medical Association Conference, the largest professional body, globally. Now, I would like to highlight a few aspects of hypertensive emergencies. Hypertension is a common agenda, around 20% of the population have it. Wherein these emergencies, how do you occur, what are the different types, how to differentiate, and then, how to, manage, that's a way I will be dealing with. Then we will see what is the conclusion. See, there are JNC classification, earlier was 7, current one is JNC 8. That has set the levels of hypertension, the blood pressure to be called as hypertension very low. Systolic blood pressure should be lower than 120 and diastolic 80, that is normal. Up to 140, it is called as pre-hypertension. Stage 1 is up to 159. Above 116 means it is stage 2. That is the current JNC classification, which all of us know that. And there are various other classifications also. I have just compared here. One is, J7, as I told you, JNC 8. Another is American College of Cardiology and American Heart Association. All of them have lowered the level of blood pressure. What does it mean is, blood pressure must be well maintained at a lower level so that systemic complications are less. That is the meaning that we want to confirm. Now, the global burden of hypertension in 2025, in 2000, 26.4% of the world adult population had hypertension. In 2025, it will come up to 29.2%. 972 million adults have it, it will come to 1.56. But the major issue here is only 20% will be in developed nation, whereas 80% will be in developing nation like India, Asia, and Africa. It's an important point for us to note. And if you analyze the hypertension of the normal people, only about 20% of them know that they are hypertensive. And in that, the confirmed diagnosis is around 32%. Of the hypertensive people, only 30% have been treated. Of the treated hypertension, only 30% have controlled hypertension. Overall, only 15% of the total hypertensives have controlled blood pressure. That is a major issue. That is why I am very keen to give this communication. There is an entity called a hypertensive crisis. When you will call it a hypertensive crisis, when the sudden rise of blood pressure is above 180 to 120 or greater. This has been divided into two categories: hypertensive emergency and urgency based on the target organ affection. And only 1 to 3% of hypertension will have an emergency. Out of that, 1/4 of them will be emergencies and 3/4 of them will be urgencies. This is the data available here. And the criteria is there is an acute hypertension elevation. You do a physical examination and signs of an end organ dysfunction, either a fundal or a renal or a cardiac or a cerebral. Always you say when it is there, it is an emergency. You need to go into look for very severe complications like aortic dissection, stroke, preeclampsia. When target organ damage is not there, we label it as an urgency. You can always manage it little coolly. And the hypertension emergencies, as I said, target organ dysfunction can have an encephalopathy, a dissection, ICH, or a preeclampsia, whereas urgency has no target organ damage, can have a coronary artery disease like an acute coronary syndrome, accelerated hypertension, or a renal issue, or a post-operative, intraoperative, all can be there. These are the various complications of hypertension. Target organ damage, and a stroke, and a heart, a coronary disease, heart failure, or left ventricular hypertrophy, retinopathy, peripheral vascular disease, or a renal failure. All these can be there. And as I told you, depending on the target organ dysfunction, we classify it into either a emergency or an urgency. That is how we always locate it. And hypertension emergency, there are a few categories there. One is an accelerated hypertension, a recent, previously it was going on well, a recent hypertension, sudden upstroke of hypertension, can have a target organ damage like a fundal hemorrhage. Malignant hypertension, blood pressure is more than 200 to 140 with retinopathy or papilledema. Episodic or paroxysmal hypertension, now and then goes high and comes down. Resistant hypertension is the one have a control that is called as a resistant hypertension. And there is an entity called a neurogenic hypertension. Somebody has a stroke, somebody has an intracranial bleed, somebody has a sleep apnea, somebody has a brain tumor. You can always have a hypertension due to an increased, sympathetic discharge from the hypothalamus or a limbic cortex, which you will have to always remember. The common causes of hypertension emergencies are listed here, but I, for the one who will say, commonest cause is discontinuation of antihypertensive medications, especially clonidine and beta blocker. They frequently develop a crisis. There are many other causes also. Pheochromocytoma, renal causes, and as I said, hyperthyroidism, or a brain tumor, or drug uses, all can be there. But the commonest, as a clinician, I would like to say, a withdrawal of the drug. They will always say, my BP is normal, why should I take it? These are the various clinical examples of hypertension emergency and urgency. Pheochromocytoma, always you must keep it in mind. As a clinician, when there is a triad of headache, palpitation, sweating in hypertension, always think and rule out pheochromocytoma. A simple CT of the abdomen will be able to do that, or a catecholamine level estimation will confirm the diagnosis. This is what happens in the hypertensive crisis. You have a BP which is going on rising, autoregulation failures, resistance increases, vasoconstriction, endothelial damage, ischemia, the RAS system is activated, goes for a target organ damage. And the signs and symptoms vary depending on the system that is being affected. Can be a cardiac pain, can be a severe headache, confusion, blurred vision, nausea, vomiting, shortness of breath, seizures, or suddenly can be unresponsive. And these are the clinical scenarios. Neurologically, you can have hypertension, encephalopathy, infarction, hemorrhage. It's about 4%. Ischemic infarction is more. Cardiac can be a coronary artery disease and myocardial infarction, 12%. Pulmonary edema is more common. Can be an aortic dissection, eclampsia, acute renal failure, ocular hemorrhages, and commonly in COVID pandemic, you have an hypertensive urgency, whereas ACE inhibitors or calcium blockers are very useful. You will have to make an accurate diagnosis before managing, and you will have to measure the BP, look for fundus and target organ damage, and then ECG, renal, echo with the color Doppler. If there is a central nervous system involvement, a magnetic resonance imaging is always needed. You will have to, when the patient comes to the emergency room with a hypertensive emergency, these are the differential diagnoses that should pass through the mind of a physician, like a migraine, abdominal aneurysm, pregnancy, Cushing's, or a glomerulonephritis, pheochromocytoma, vasculitis, coarctation. A physician examining the case should keep these things at the back of the mind. And these are the guidelines for treating hypertensive emergency. Hypertensive emergency has to be hospitalized, no outpatient treatment. There is a statement that hypertensive urgencies can be treated in daycare center. When blood pressure controlled reach the control level, can be sent home. But I, for the one who believe, always keep the patient under observation at least for 24 hours, even if there are no target organ damage. Goal is very important. We not reduced by 25%. He had about 200, at least 25 millimeters of mercury has to be brought down in 2 hours time. In 6 hours time, blood pressure should be brought to 160 by 100. In 24 hours time, it should be brought to normal. That is most important. And these are the antihypertensive drugs available. In emergencies, we talk about intravenous drugs. Earlier we used to give sublingual drugs. A sublingual nifedipine, even nitroglycerin or sorbitrate, all these are gone today because they have been proved to cause very fatal effect. Therefore, we should go for intravenous therapy within about 15. ரூபாய் செலவழிச்சுக்கிட்டே இருக்கிறேன் எங்களை ஒன்னே காணும் 10 நிமிஷம் ஒழுங்கா இருந்தா முடிச்சிருப்பேன். இன்டர்நெட்டை கொடுங்கல. ஹலோ, அது கட் ஆயிடுச்சு. The intravenous drugs have to be used. The ideal drug can be a nitroglycerin, which is very ideal, especially when there is a coronary event, when there is a left heart failure. But see that BP doesn't fall down too much. Intravenous labetalol and intravenous diuretics, sodium nitroprusside and magnesium mannitol, these are all the drugs available to treat the hypertensive emergencies. These are the various drugs as per the categories. The vasodilator side, you have noted sodium nitroprusside, but nitroglycerin and androstenedione are the commonly used drugs. And enalapril is available intravenously, very good drug. Beta blockers like labetalol is an excellent drug available today. Metoprolol was available earlier, but not now available. These are all not available in India for our day-to-day practice. For academic reasons, it has been given. Depending on the clinical scenario, which drug you can use. Can be, if there is hypertensive encephalopathy, nitroprusside, labetalol, or nicardipine. On acute pulmonary edema, nitroglycerin is the drug of choice, and enalapril diuretics. Cardiac ischemia, again nitroglycerin, beta blocker. Aortic dissections, nitroprusside and beta blocker. Adrenergic crisis, beta blockers, labetalol. Eclampsia, hydrolysine is a drug. These are based on the disease condition or the complication. These are all the oral drugs. Any textbook of medicine will give it to us, right? From vasodilators, AC inhibitors, ARBs, and then alpha-2 agonists and alpha-1 blockers and beta blockers. Sublingual drugs, as I told you, are available, but we'll have to be very cautious. This is how we manage hypertensive emergency. The diastolic blood pressure more than 120, immediately start a nitroglycerin infusion. No effect, you can go in for a enalapril, add a diuretic. Alternatively, you can start with the labetalol and you can increase the labetalol. Usually, gets controlled with 80 milligram IV labetalol. Other drugs are sodium nitroprusside, esmolol, and nitrilacid. Ultimate aim is within 2 hours, 25% of the BP has to be brought down. Within 6 hours, 160, the systolic and diastolic 100 should come. Within 24 hours, blood pressure should be made normal. It's an acute blood pressure elevation. These are the evaluation. If there is end organ failure, it is an urgency. You can very easily handle it. It's an emergency. It's aortic dissection, CT angio, heart failure, ECG echo, tubular necrosis, renal function, stroke, cerebral imaging, pre-eclampsia, biochemical analysis, so that we proceed with the management. One important thing is a tele-hypertension management. When the patient is linked, by telemedicine or telehealth with this clinician, this rise of blood pressure can always be prevented. Beyond a particular level, a warning will be given so that he will immediately reach the doctor. We can avoid it. Now, these are a few clinical clues. Always suspect hypertensive patient with epistaxis. Little low when you see the patient. Yes, already done the bleeding, therefore BP can be little low, but don't get, cheated. Neurological examination is very important. Heart failure always reduce the BP quickly, whereas in stroke, reduce the BP slowly. Either you will aggravate the thrombosis. There may be a seizures which you need to, carefully control, avoid using sublingual nifedipine. Stroke presenting as hypertension is the most common cause of death in emergency, more than cardiac. Therefore, the recommendation in hypertensive emergencies is evaluate the target organ affection and start treatment immediately. Intravenous drugs are the key. Reduce BP quickly in left heart failure, but slowly in stroke to target level. Beware of sublingual nitroglycerin or amlodipine. Switch over to oral drugs soon after controlling the emergency. Always evaluate, keep in mind and evaluate the for secondary cause of hypertension like renal artery stenosis or pheochromocytoma. Thank you very much. Thank you very much.